Good afternoon, everyone, and welcome to the sixth annual Prenatal-to-3 Research to Policy Summit. I'm Cynthia Osborne, and I have the privilege of directing the Prenatal-to-3 Policy Impact Center at Vanderbilt University. And we are so thrilled that you are joining us to learn more about the policies that are making a difference and making it so that kids get off to a healthy start and thriving. Many of you joined us at our event in December, in which we brought teams from every state together to talk about the progress that states have made over the last 5 years or so in really implementing those policies that we know are so important for children. And we also asked you what your plans were for your states for this legislative session. And boy, did you guys get busy. There was so much that folks were trying to do. We tracked over 1,500 bills, all related to the types of things that are effective and that we know make such a difference. So we want to celebrate that today. And I'm going to share with you not just what we know that we've been sharing in years past about what effective policies really help families get off to a healthy start and thrive, but there's 5 new ones that we have identified that we want to make sure that we learn more about what states are doing in that area. And I'm going to spend some time giving an overview of some of the progress that states have made toward implementing these effective policies over the past year. And I'm also joined by 3 of my colleagues who have been the ones really tracking what you've been doing, and they're the experts at what states, what's possible in states, what states have tried, what they've been successful in, and they're going to share their insights with you today as well. And we're going to be able to hear from my colleague, Elizabeth Burak, who's going to share with us what we should really be thinking of with regard to some of the recent federal policy changes that occurred in the reconciliation bill this summer. And then I'm really excited to introduce a brand new tool to you today that we're going to show how you can use it to really model how all the policy choices that your states have made interact to provide resources for a family. So we'll have all of our guests joining us throughout the next hour and a half together, and I'm excited to get started. So, as most of you who are on this call are aware, that the reason that we exist as a center is because the science of the developing child is so strong and informs us about how important those earliest years are for children's healthy development. That we know that if we can provide a safe, stable, nurturing environment in those earliest years, that sets children up on a lifetime trajectory of health and well-being. And by contrast, if our children are exposed to adversity in these earliest years or not in these nurturing and stimulating environments, that has detrimental impacts to both the developing brain and all of the body's systems that also has lifelong consequences. So my center wanted to step in and say, well, if we know what we need, the environment that we need to create for children, what are the policies that states can implement that can really help to foster that sort of environment? And we operationalized all the science of the developing child into these 8 prenatal-to-3 policy goals. And they're pretty broad, but again, these are the conditions that if we could make it so that every child experienced these conditions in early childhood, that they would be set up for a lifetime of success. So making sure that families have access to the services that they're eligible for and that they need, that parents can both work and care for their children, that children have sufficient resources, thinking about both their economic security as well as their food security, housing stability, that our babies are born healthy to healthy parents. And we think not just about their physical health, but about their emotional and mental health as well. That our parents really understand how important their role is in nurturing their children's healthy development, that they have both the skills and capacity and time and understanding to engage in those nurturing behaviors. and that when our babies are not with their parents, that they're also in these nurturing environments, and that we're thinking about our childcare educators, our home visitors, our behavioral support specialists, the whole ecosystem of early childhood, and that our children have access to the things that they need to really promote optimal development. So, breastfeeding or immunizations, that they are also, that we can identify any sort of delay that they're experiencing as early as possible and get them those services that they need to get them back on track for optimal development. So, again, that's the environment that we're trying to create. And what we did was turn to the evidence to say, well, what are the policies that states can implement to create that environment? So if you think of that family being surrounded by those 8 policy goals, and that's really the environment that we're trying to create, that these are the policies and strategies that we have identified to date that help to really create that environment, that foster healthy development and ensure all children thrive. And that we've learned, and as I've said many a times, that there's not one policy or strategy that's going to do it all. It does take a system of support that's a combination of broad-based economic and family supports, as well as more targeted interventions, and that focus not just on early learning, but also on children's and parents' health and their economic security and family strengthening. And we can break these up into these 3 different buckets, and I wanted to make sure to introduce to you the new strategies that we've identified over the past several months that have an evidence base that they will make a difference in improving the lives of infants and toddlers. And these include a perinatal telehealth services. So they have been shown to be just as effective as in-person services for many of the types of outcomes that we're looking for. And this is very helpful for rural areas or families that face transportation hurdles. We're also adding to the roadmap cash transfer programs that provide economic security to families and new strategies in our early care and learning, both shared book reading programs like Reach Out and Read, our emergent literacy coaching programs like Lena, and thanks to several states that have been developing these sorts of effective policies, they've shown us what we can do to try and retain our child care educators. So these are the now 17 policies and strategies that states can implement that have an evidence base that they will make a difference. And those of you who are watching usually think of yourselves in one of these buckets that I study early learning, or I really care about economic security, or I'm a maternal and child health specialist. But I wanted to kind of break down these silos as much as possible and introduce the idea that these policies and strategies are really cross-cutting, that one of the most effective policies that states can implement to improve adverse birth outcomes is raising the state's minimum wage. That when we think about economic and family supports, actually providing health insurance is one of the most important programs that we can have to reduce child poverty. And when we think of early care and learning, it goes well beyond just child care to allow parents to be their children's first teacher and to really support the home in myriad ways. So we want to kind of break down those silos of how we think about policies to support families and think of it more systematically and how across the board, these are policies that are going to be meeting at least one of these goals. Most of you hopefully have seen our roadmap. Internally, we call this our grid, and it shows how those 8 prenatal-to-3 policy goals align with each of our policies and strategies. I'm just showing you the policies here, but it's meant to be a tool for you to use in your state, for you to begin by saying, well, what is the goal that we have for our children and families? And for instance, perhaps is that you want to make sure that your babies are born healthy, or you want to reduce maternal mortality. And you can come to the roadmap and see which policies and strategies are aligned with that goal, and really think about how you could focus or prioritize on those to help you meet your goal. Or you may have in mind that you really want to implement a particular policy in your state, and you can use the roadmap to show the types of impacts that that policy will have on various goals. Paid family medical leave programs are the policy that really impact the most goals, so 7 out of 8 of our goals. And there are some that really are very targeted and others that are wide ranging. Also, with these new emerging strategies, when you go to our website and you see our roadmap on the left-hand navigation, we now have a summary of each of these 5 emerging strategies. And we are still in the process of identifying state levers to make it so that more families would have access to these, or how states can do these at scale at the most effective way. So more information to come on these emerging strategies. Well, I want to spend a little bit of time talking to you about some of the policies and strategies on the roadmap, and look at how they really vary across states. Usually every year I come to you and say, well, we're really excited because a new state has adopted and fully implemented one of the roadmap policies or strategies. And this year, we haven't actually seen any state fully implement one of the effective strategies since our roadmap last year in October. But you can see that some of the policies, we have about half of states implementing them, a state minimum wage that's at least $10 an hour, a state earned income tax credit that's at least 10% of the federal credit and refundable, and others in which nearly every state has implemented, like expanding Medicaid, and other that is where just a handful of states so far have implemented this, but there's a lot of energy and more states are sure to follow. When we look at Medicaid expansion, there are 41 states, as I said, that have implemented the Medicaid expansion under the Affordable Care Act. And it's exciting that Montana this year passed a state law that now the expansion is now permanent. It used to that it expired periodically and they had to legislate it again, and now they've made that permanent. And we didn't have as much energy this year as we've had in years past in terms of Medicaid expansion among those states that have not yet expanded Medicaid, but still 6 of those states did introduce legislation. For paid family medical leave, you'll hear there's just so much energy across the country about this policy, and 10 states have fully implemented it, and 4 other states have enacted policies that will implement it in subsequent years. So Delaware, Minnesota, and Maine, you're all coming up in 2026, and Maryland has delayed its implementation again and now is set to implement in 2028. There were 16 other states that actually considered legislation for a statewide program. And what has been very popular is states implementing paid leave for their state employees. And we can talk at another time about how that is a real expensive way of doing it. But it is nice that at least state employees have that option. With regard to the policy changes that we've seen, both California and Rhode Island made it so that families now will get more of their wages replaced as they're on leave. Colorado lengthened duration of its leave for babies in the NICU, and Rhode Island increased the duration of its leave from 6 to 7 weeks, and it will go from 7 to 8 weeks next year. Hawaii passed a statute that is putting together a study commission to consider implementing paid leave there in subsequent years. And Virginia passed a 12-week program, but it was vetoed ultimately. And paid leave varies so much by state in terms of the amount of weeks that families can take, the amount of wages that are replaced, who pays for it, whether it's employers only, whether it's shared, or whether it is paid for by the employer only. And you can really see the wide variation across the country in the level of benefits that families are eligible for. And remember, with statewide programs, families have all paid into these programs, and this is the benefit that a median wage worker would receive if they took their leave. And this year, we also saw a lot of energy in the minimum wage. 30 states have a minimum wage that's at least $10 an hour. And that is the level of wage that the research tells us is really necessary in order to see the benefits that are associated with a minimum wage. 24 states increased their wage this past year. And some of the increases were relatively small and others were large, like in Michigan. But even a 25-cent increase in the minimum wage adds an additional $500 in income for a full-time worker. And that's enough to cover up to 4 weeks of groceries for a single mom with 2 kids. So it can have a really big impact, even though it might seem like a small change. And something that I was really, you never thought I would see so soon after doing this for the last 6 years is that now more than a third of states will be at $15 an hour by 2027. And that's just by statute alone. 12 are already there, and 6 more are on their way. Both Missouri and Alaska passed ballot measures to increase their minimum wages. Michigan and Rhode Island enacted increases this past legislative session. And Virginia also enacted legislation or passed legislation for a $15 minimum wage, but that was vetoed. And with the federal earned income tax credit, we have 23 states that have a refundable earned income tax credit that's at least 10% of the federal credit. And again, this is the level of credit that the research says is needed in order to really start to see these benefits that accrue to families. But there were several states that expanded their credits this past year: Connecticut, DC, and Virginia. And there were 27 states, more than half the states, that introduced legislation to expand or enact one. In Connecticut, families will get an additional $250 for their credit. Virginia made their credit fully refundable at 20%. DC went from 70 to 85% for families with children. They're going up to 100% next year. And Montana and Vermont both enacted increases that will take effect the next tax year. But you can see across the country the variation in what states actually provide in terms of the earned income tax credit, ranging from, in DC, 85% of the credit to 4% of a credit that's refundable in Wisconsin for families with one young child. With childcare subsidies, my colleague's going to share a lot more of what's happened here, but you can see that there is a lot of energy towards states thinking about how they can make more families able to access high quality care that's affordable. And there is a wide range in what states are actually doing to make this possible. And the first is that they're thinking about their income eligibility limits. The federal government allows states to make families eligible up to 85% of the state's median income. But you can see that the range across states is quite large. And when you think about it in terms of the federal poverty level or actual dollar amount, you can see that in Georgia, a family has to make less than $27,000 a year to be eligible, whereas a family making over $150,000 a year is eligible in Vermont. And New Mexico recently announced that they're going to make child care universal in their state. And this just shows you, when you're thinking about state median income, what the variation really looks like across states in terms of who is eligible. But when we really think about how much families have to spend, that varies considerably across states as well. In New Mexico, in a handful of other states, they're spending 2% or less of a family's income on any child care if they have a subsidy. Whereas in some states, they're spending close to 20 or over 25% of their income. And when we look at the changes that states have made this past year in their reimbursement rates, there are 15 states that are setting their reimbursement rate at what the federal government calls the equal access rate, which is the 75th percentile of the state's market rate. And there are another 5 states that are using cost estimation models, and Massachusetts joined that group this year. And you can really see that the changes that states make a big difference for what families have to pay and what providers are actually able to receive. So in Kentucky, the providers are going to receive the same amount this year as they did in the prior year, but the state will pay more of that. And so the family's copay is reduced. In Michigan, providers are actually going to get paid more, and the families are not going to have to absorb that cost. In Minnesota, the market rate went up and the state kept pace with the market rate. And so the providers will get more and the families will continue to pay their share. Whereas in Tennessee, the market rate value stayed the same, but the state is going to pay a little less and families are going to have to pay more of whatever providers receive. So lots of changes going in lots of different directions with regard to reimbursement rates. The last strategy I'm going to spend any time on is doulas because there's so much energy. This is a timeline that shows you over the last 2 years, nearly 15 states began using Medicaid to reimburse doulas, and there are seven additional states that are in the process of doing this. So this is, a huge change from times past, and you can also see the variation across states in what they're actually allowing doulas to be reimbursed for and the amount. Um, so lots of energy at the state level and so much going on that we've been tracking. And I want to introduce to you now 3 of my colleagues who have been instrumental in tracking. Many of you probably followed their weekly updates that they shared about what states are doing. So please join me in welcoming Alyssa Rafa and Sarah Ritter and Maria Spinetti, who are going to share with you what they saw in states over this past year, and what we may be seeing as the next year rolls around. Sarah, do you want to get us started?
Great. Yeah, thanks, Cynthia. So hi, everyone. I am going to briefly cover some of the high-level progress that we saw this year in paid family and medical leave, state minimum wages, and tax credits. So first up with paid family and medical leave, as Cynthia said, we saw continued momentum this legislative session in both states with already existing programs, as well as exciting incremental progress in states that have not yet adopted a statewide paid family and medical leave insurance program. So for statewide programs, Virginia did get close again this year. The legislature passed a bill which would have created a new 12-week statewide program, but the bill was vetoed by the governor, and this is the second year in a row that the governor has vetoed such legislation. Colorado enacted a bill which doubled the duration of their leave available to families with a baby in the NICU from 12 weeks to 24 weeks. And Rhode Island enacted legislation to increase the wage replacement rate for paid family leave beginning in 2027. As I mentioned, we also saw some really exciting incremental policy change this year. So continuing a trend that we've seen over the last several years, 3 states enacted legislation to provide paid parental leave to state employees for the first time: Alabama, Iowa, and Mississippi. And Wyoming also adopted an administrative rule to provide 6 weeks of paid leave to eligible state employees for the first time. Other states enacted legislation or adopted administrative rules to expand the paid leave that they provide to their state employees. And in addition, Hawaii adopted a bill to commission a paid family and medical leave working group, which will provide recommendations for a policy to the state legislature. Moving on to state minimum wages, we didn't see as much progress regarding state minimum wages in terms of legislation this year. However, during the legislative session, we did have 2 states, Michigan and Rhode Island, that enacted legislation to increase their state minimum wages. The legislation that was in Michigan also had a provision which repealed the elimination of the tipped minimum wage. So tipped workers in Michigan were going to be paid a cash wage, which doesn't include tips. that was the same as the regular minimum wage by 2029, but this legislation repealed that provision. So, and similarly as with paid leave, Virginia came very close to enacting legislation to increase their minimum wage this year. The legislature passed a bill which would have incrementally increased the minimum wage, but it was also vetoed by the governor. And this year, we also saw continued progress related to sub-minimum wages for workers with disabilities. So if you're not as familiar with this, employers can provide a certificate, which is known as a 14C certificate, which allows them to pay certain workers with disabilities a minimum wage that's less than the federal or the state minimum wage. But there's been a trend in recent years in states eliminating the use of subminimum wages for workers with disabilities. And this year we saw two more states, Georgia and Illinois, enact legislation to phase out and fully eliminate the subminimum wage for workers with disabilities in the future. So, in terms of family tax credit policies, moving on, we continue to see bipartisan support for tax credits that support working families this year, such as the Earned Income Tax Credit, or the EITC, and the Child Tax Credit, or the CTC. So, for EITCs, as Cynthia mentioned, 4 states enacted legislation to increase the generosity of their state EITC this year. Connecticut boosted its credit by providing each additional family with another $250 credit. Montana doubled its EITC from 10% to 20% of the federal credit, and that will begin in tax year 2026. Vermont increased its credit for workers without children in their home to match 100% of the federal credit, beginning in tax year 2026. And Virginia temporarily increased its refundable EITC from 15% to 20% of the federal credit. For CTCs, this year, one state, Georgia, enacted legislation to create a new CTC. So Georgia's new non-refundable CTC will be worth $250 per child under the age of 6 and will be available beginning in tax year 2026. And other states expanded their existing CTCs this year, including Maine and New York, which increased the generosity of their credit, and Maryland, Utah, and Vermont, which expanded eligibility for their credit. One other interesting trend that I'll mention that we saw in tax credit policy this year was newborn credits, newborn tax credits. A trend that sort of emerged this year was states considering a newborn tax credit or a credit that's available for the first year of a child's life. So this is definitely something that we're going to be keeping our eye on next year as well. So yeah, that's just a snippet of the progress that we saw in economic and family support policies. Be sure to check out the roadmap to read more. But for now, I will pass it off to my colleague, Maria Spinetti.
Thank you, Sarah. And today I'm going to be talking about legislative action on early learning. I'm going to be particularly looking at subsidy and childcare funding, as well as subsidy policy, and looking at business supports, licensing regulations, and the childcare workforce. Jumping straight into funding, states can support childcare programs and early learning programs through 2 ways. One is through the use of general funds, and the other one is through dedicated funding streams. In the past year, the biggest trend that we saw was of states increasing their state general funds to go towards childcare subsidy. And we noticed that 18 states significantly increased their funding for fiscal year 2026. We understand that though there might be additional state funding going into these programs, the states might still be grappling with the expiration of federal relief funds, and they might still have smaller budgets than in past years, but this is still a move towards increased state investment to childcare. And we know it required a tremendous amount of work, as some states were also dealing with reduced budgets. And then the other way in which states can support childcare or early learning is through dedicated funding streams. These are sources through which a state generates revenue. Think tourism taxes, think property taxes, sports betting taxes, and then they are earmarked for a specific purpose. And in this case, we're looking at those that are earmarked for early learning. So in the past year, 2 states created dedicated funding streams. One was Montana, which created an early childhood account, initially with $10 million, but it will continue to receive annual surplus funds to support early childhood programs across the state. And then Connecticut also created a dedicated funding stream through the Early Childhood Education Endowment. They seeded it with $300 million, and it will continue to receive future unappropriated funds. This endowment will fund Connecticut Early Start, which is not your childcare subsidy program, but it does provide financial assistance to families. And then if you're aware of dedicated funding streams, you might know that other states also have them. And this year, New Mexico and Louisiana, who already have pre-established ones, made changes to their streams to increase the amount of funding available for early learning programs. Switching gears from funding to levers for childcare subsidy policy, in this case, we're talking about our three levers, which are income eligibility, co-payments or family co-payments, and reimbursement rates. We saw very little movement with reimbursement rates having the biggest changes, with 6 states through their state budgets increasing rates in the future. But the biggest news was from New Mexico, which came just a few weeks ago when they announced that they were moving towards free universal childcare for families, regardless of their income. It will become effective November 1st, so you won't see it just yet in our data in the roadmap. But once it does, New Mexico will be the very first state to remove all income limits for childcare subsidy, and also will continue to be the only state to waive co-payments for all families in their subsidy program. Outside of our levers on childcare subsidy at the center, we also track childcare policy more generally, and you can find that information in our childcare subsidy narratives. Today, I want to touch on 3 themes that we noticed this year. One being on employer-supported policies, which is a trend we have seen in the past few years as well. The first one being on tax credits, with Alaska, Georgia, North Dakota, and Utah all creating tax credits for employees who either contribute directly to an employee's childcare cost or who help contribute and help increase available childcare programs in the state. Colorado already had a program, but it was set to expire, so this year legislators extended it for 3 more years. And also within that umbrella of employer-supported policies, 2 states, Ohio and Missouri, through their budget, allocated funds to create cost-share programs. These are programs in which employers, employees, and the state all cover a portion of the childcare cost for an employee. And this is also a trend that we have seen in the past few years. And looking more into regulation, this year we saw that several states dealt with several bills to increase childcare ratios and group sizes, meaning that the same number of adults can care for more children. Ultimately, Idaho and Indiana increased ratios, and North Carolina group sizes. Idaho's bill initially would have fully removed all ratios from statute, but the bill that was enacted did include some, though more lenient, than what was previously established. And finally, looking at the childcare workforce, which is, as we know, the backbone of our entire childcare system and faces lots of challenges due to inadequate compensation, both through wages and benefits. We know and we have seen states doing different things throughout the past few years to increase the supports available for the workforce. This year, Oklahoma enacted legislation to provide childcare subsidies for the childcare workforce. And governors in Maine, Montana, and South Dakota vetoed legislation for the same purpose of providing subsidy for the workforce. Additionally, Arkansas enacted legislation to allow early educators to participate in the K-12 teacher retirement system. And Connecticut will be piloting a program to provide health insurance for early educators and childcare workers. That's a wrap on early learning policy for this year. And with that, I'm going to pass it on to my colleague, Elisa Reifa.
Thanks, Maria, and thanks, Sarah. So now let's dive in a bit, first on state doula policy and then a bit on SNAP and Medicaid. So as Cynthia mentioned earlier, for several years now, we've seen a lot of states really investing in community-based doulas as part of their larger maternal health ecosystem. And this year alone, we saw 35 states introduce legislation related to doulas, and there were some really big wins across the country in this space. There were 6 states that newly implemented Medicaid coverage for doulas and another 6 that enacted legislation to implement coverage over the next year. And with these new implementations, Washington now has the highest reimbursement rate for doulas in the country at $3,500 per pregnancy. Many states that already allow Medicaid reimbursement for doulas are focused on improving their existing policies. So Oregon and Virginia enacted legislation to increase the amount of visits or visit hours covered through Medicaid, and Maryland and Michigan are in the process of implementing rate increases for doula providers. States are also doing a lot of work to support the doula workforce. So in 2025, another 6 states appropriated funding for doula training, continuing education, or administrative assistance for doulas. And then we also saw quite a few states looking to
encourage doula-friendly hospital policies this year. In Illinois, Maryland, and Virginia, legislation was enacted to require that hospitals allow doulas to accompany patients during labor and delivery. And legislators in Connecticut created a work group focused on exploring those more doula-friendly hospital policies. And now for some detail on what we saw in states on SNAP. There was a really wide range of state action on SNAP this session, including everything from states working to decrease the administrative burden associated with the program to states restricting the types of foods that families can purchase using SNAP benefits. So in this 2025 session, Oklahoma and Maryland enacted bills to make SNAP more accessible. Oklahoma's bill will expand on their existing common application by requiring the development of a more integrated system that will include several programs like SNAP, TANF, Medicaid, WIC, and energy assistance. And Maryland streamlined its benefit application and online platform in July of this year, allowing residents to apply for many of those same programs I just mentioned, including SNAP, through a single application. And then we also saw similar legislation to this introduced but not enacted in Illinois, Indiana, New Jersey, and New York this year. The most widespread trend we tracked related to SNAP this session was around restricting what foods families can purchase using SNAP benefits. So at least 20 states introduced bills to prohibit the purchase of certain foods, most commonly soft drinks and candy. Of those 20 states, Idaho, Texas, and Utah enacted their bills, and Arizona and Kansas passed bills that were ultimately vetoed by their governors. And last but certainly not least, state action on Medicaid. Not unlike some of the other issues we've covered, much of what we saw this session in states was taking place amid a ton of uncertainty on federal changes, which we'll get into a little bit more in the next part of our program here. In addition to some legislation to expand Medicaid and extend postpartum coverage, we also saw states looking at work requirements, trigger laws related to federal matching rates, and limiting state agency authority to alter Medicaid programs. So some specific examples. This session, 6 of the 10 states that have not yet expanded Medicaid proposed legislation to do so. None of those bills passed, but Montana's legislature did prevent that state's expansion program from expiring by enacting a bill to eliminate the termination date for the program. This bill was coupled with the addition of work requirements. In Idaho and Iowa, they began implementing their 12-month postpartum extension this year. So now 49 states, including DC, have active 12-month postpartum coverage extensions. And the 2 states that have not extended yet introduced legislation this year to do so. Legislators in Arizona, Idaho, South Dakota, and West Virginia introduced bills that would trigger the rollback of Medicaid expansion if federal matching rates were to decrease, also known as trigger laws. This reduction in the federal matching rate was one of those scenarios being considered by Congress prior to the passage of H.R. 1, and South Dakota of those 4 states was the only one to pass its proposed policy, which will head to the ballot in the next general election. If it's approved by voters, South Dakota would become the 13th state with a trigger law on the books. And states also continued to pursue work requirements. 11 Medicaid expansion states introduced and 5 ultimately enacted bills that require their Medicaid programs to seek waivers for work requirements. And then finally, legislators in Idaho, Kansas, and Kentucky limited their state agencies' authority over Medicaid, now requiring explicit legislative direction before those agencies can make certain changes to the program. So a lot going on at the state level on these policies, and we have a lot more detail, like Sarah said, on all of these legislative trends that we've outlined and more that you can check out in the roadmap. Thanks, Cynthia.
Well, thank you, all 3 of you, for sharing what you've been seeing and what we've been learning. And like you said, you've summarized it all in the roadmap, and they can go and get it all there. And what you covered is only just this kind of a smidge of what's there, but lots of activity. Thank you again for joining us today. And we're going to go now to talk more about what states need to be thinking about with regard to federal changes. Before I go too far there, I did want to just say that I completely forgot to remind everyone to use the Q&A function of the Zoom to ask your questions. I'm glad to see that it was in the chat, that you have been asking questions. My colleagues will be answering them, and you'll probably have a lot of questions for our guest, Elizabeth Barak, here in a minute. So please use that. Also, at the bottom of your Zoom screen, there should be a way for you to log in and see some of our resources that are available to you that go into kind of great detail of all the things that we've been talking about. So, as you all are aware, this last summer in July, we passed a reconciliation bill that has significant consequences for states in several ways. Two of the policies that will really impact states' budgets quite substantially in the near term are the changes to SNAP policy and the changes to Medicaid policy. And mind you, I'm not talking about what may happen today with the continuing resolution. I'm talking about what happened in the reconciliation bill. And my colleague Elizabeth Barak is going to share with you about Medicaid, but I just wanted to provide just a brief overview of SNAP and what's happened there, and to make sure that each state is really digging in to understand how it's going to affect your state, because all states will be affected differently. We do know that the work requirements are changing, especially in terms of the age. We know that it will no longer be available for folks seeking with refugee status or seeking asylum. But probably the most significant is the new cost sharing. So this time next year, October 1st, 2026, every state is going to have to change from covering 50% of your administrative costs to covering 75% of your administrative costs. And in Tennessee alone, that's about $67 million a year. So you need to really find out what's going on in your state and how big of an impact that's going to have. But the next year, states are going to have to begin contributing a portion of SNAP benefits based on their error rates. And I just want to be really clear that when I say error rates, I mean mistakes that are made in the processing of the SNAP benefits, that these are state workers who make an error and they get counted, whether they're paid too little or too much. This is not about fraud. And what's going to happen is that states with higher error rates will have to pay a bigger portion of their benefits. And the things that reduce error rates are also the things that are in the roadmap about reducing administrative burden. So the fewer times that state workers have to process claims, the kind of reduces every time it reduces the rate of their errors or likelihood of making a mistake. And so states that are doing broad-based categorical eligibility or states that are lengthening recertification intervals or that are doing simplified reporting, all of these things help to reduce your error rate. In Tennessee, for instance, if our error rate remains the way that it was this past year, that's between $100 and $200 million that the state will have to pay in benefits. So that's SNAP. The changes among Medicaid are even more complex. And the reason why we care about them for lots of reasons, not just for healthcare coverage, but nearly everything that is on the roadmap can be paid for by Medicaid. And so as states are going to be considering how to make cuts, we're afraid that states will cut some of these evidence-based programs that we know have such an important impact on parents and their children. But I'm joined today by my colleague, Elizabeth Barak from Georgetown, who is going to share with us much more about what states should be thinking as these Medicaid changes are rolling out. So welcome, Elizabeth. I'm grateful that you're here.
Thank you so much for having me. And I'm going to do that transition in hopes my slides go forth.
I can see them. They look great.
So really can't thank the Prenatal-to-3 Policy Center and their team enough for doing these roadmaps. They are such a helpful chart of a lot of the state progress that's been going on, particularly in the Medicaid space, which of course you just heard. So really thrilled to partner with you all. For those who aren't familiar with the Center for Children and Families, we're a policy research center with a mission to improve healthcare coverage for children and their families. And we spend most of our time trying to unpack all of the complexities of Medicaid and the Children's Health Insurance Program. So Medicaid is 60 years, just turned 60 years old this year. And one of the things we've learned over those decades, as states have expanded access to more pregnant women and more children and more family members, is we've been able, and economists in particular, have been able to see the impact of Medicaid over time. And what has been really fascinating to see over the last few years is the longitudinal research that has shown that not only is Medicaid a critical support for health outcomes, and it does improve health outcomes for kids well into adulthood, it's also really important for educational and economic outcomes, not just for the children of folks in Medicaid, but even there are even new papers showing two-generation success in folks. A woman who is pregnant and covered by Medicaid, that woman's granddaughter or grandson would enjoy better health and birth outcomes later. So it's really an important investment in the long term. But Medicaid has also, along with the Children's Health Insurance Program, driven the rate of all uninsured Americans to their lowest levels on record. And that's particularly been the case with children. And you'll see in 2016, that was the lowest recorded rates we have for children. And if you had seen before 2010, it would have been even higher, well into the teens for kids. And while coverage is not the only thing that's important for health for kids and families, it's a necessary protection for economic security and to make sure it's a first step to make sure kids and families get the health care they need. And if you look at 2014, you'll see this big drop for children's uninsurance rate. And that 2014 is the year that the Affordable Care Act went into effect with Medicaid expansion that the panel talked about, as well as marketplace coverage. And so we saw for many parents and caregivers, for the first time, they had health insurance coverage. And we know that when parents and caregivers get health coverage, their kids are more likely to enroll. Most uninsured children are eligible, but for whatever reason, not enrolled or have dropped off the program, fallen through the cracks. So when their parents got coverage, more kids got coverage as well. So we're worried that the reverse that could be true. We had the welcome mat effect with parents, and we're worried about the unwelcome mat effect that could be. For young children, I just put these down as a comparison. We've seen the trends largely mirror children of all ages. Cynthia mentioned this, and it's come up a lot. There's really hard to find a system that serves young kids that's not impacted directly or indirectly by Medicaid. 3/4 of low-income children under the age of 6 are covered by Medicaid or CHIP. It covers 40 to 50% of all births in this country. It is a major payer in most states of the early intervention system, or IDEA, for infants and toddlers. Most of the kids who are in the foster care system are covered by Medicaid. For Medicaid pays for the health coverage. And one aspect that not everyone thinks about a lot is the importance of health coverage for other caretakers or other adults in children's lives. So, for example, we know more than 25% of the childcare workforce is covered by Medicaid, and that's largely the Medicaid expansion's job. They really drove the rate of uninsured childcare workers in those expansion states down significantly. I think it's uninsured childcare workers are more than 4 times likely to be uninsured in the non-expansion states. So HR 1, or the big beautiful bill or reconciliation bill or whatever we're calling it, I call it HR 1. What we like to say is that we know that the health system and state budgets, and there were so many challenges that we were already dealing with. And what I'll just say here is that this bill just is going to serve, from where we sit, to exacerbate those challenges, right? We know rural providers are already on thin margins, lots of provider burnout, an existing maternal and infant healthcare crisis, mental health care crisis, and as the roadmap has shown, incredible progress and attention for the first time in many years in Medicaid on maternal health and young children's success. And so how do we continue that momentum amid some of these challenges ahead? So I think several folks mentioned some of the proposals on the table during the debate around HR 1. So I think it's really important to talk about what didn't happen, because it's hard to imagine, but it could have been a lot worse. My daughter is 14 and says no cap a lot, which I've learned is no lie, or I'm being serious. It's also literally true in the case of Medicaid and HR 1. Earlier proposals and ideas, starting with Project 2025, and even in the last Trump administration, the congressional proposals then have proposed block granting the Medicaid program. So changing the funding structure from its entitlement basis, where the federal government picks up anywhere from 50 to 76% of the cost of any Medicaid enrollee's health care, to a block grant where above that cap, a state would be responsible for any payments over that. And you can imagine, even if those cuts started small, over time, they would get a lot bigger. And so that structure is still intact, and that's really important. So when there are economic downturns or recessions and more folks need health coverage, or when we have a pandemic or we have natural disasters that force more people to have health needs, Medicaid is there to support it. We also preserved the pediatric benefit in Medicaid called EPSDT, Early Periodic Screening, Diagnostic, and Treatment. And that says every child is entitled to a service or medical intervention, any medically necessary service, certainly all their preventive screenings and all their preventive care, but also anything that a doctor or practitioner sees that is necessary coming out of those screenings is to be paid for. And there's a lot we could do to meet the potential of EPSDT, but it's very much still intact and important for kids. One of the other proposals on the table, I think was mentioned earlier, is the decrease. There was a proposal to decrease the federal match for the expansion population. Under the Affordable Care Act, when Medicaid expansion came into being, it was that just those adults in the expansion population were paid at 90% at the federal level. And there was just a lot of discussion around the fact that if you moved from that 90% down to the regular match rate, it would be impossible for most states to keep that expansion up and running. So that didn't happen as well. And then lastly, there's always, especially when you talk about many kids on Medicaid, more in recent years, half of all kids have been served by Medicaid or CHIP. It's a major payer for most any family. There's a lot of public support for Medicaid, particularly when you talk about who benefits from it. And that support has only increased across party lines. In fact, across party lines, people not only didn't want to cut Medicaid, but they actually wanted to increase payments in some situations. Oops, I went the wrong way. Okay, so here are I could do 3 different webinars on the many, many complex changes that HR 1 made to Medicaid. I'm going to try to do a really fast, high level. I would say the majority of the cuts are really targeting the Medicaid expansion, even though there wasn't a successful attempt to get the federal match cut. It did do other things to really tie the hands of many states financially. All states had some hits, but particularly states that have opted, the 41 states that have opted to expand Medicaid. And that could be a real challenge, particularly given what we know about its importance to their children's health for the many parents who are covered. It restricts, and most of the Medicaid expansion hits were on the work requirements, which I'll talk about. It really undermines states' ability to raise revenue for their state share. Every state but Alaska has used what are called provider taxes to help raise the state match portion of the Medicaid program. Some even used it to help pay for the state match for the expansion. And this bill ties states' ability to do that moving forward. No state is going to be able to create or increase a provider tax in the future. And it's a little bit more strict on expansion states. Lots more red tape and administrative burden. So Cynthia's point, there's been a lot of work, particularly in the last administration, the Biden administration, to create rules to make it easier for eligible folks to get in and stay enrolled in Medicaid, and those were halted with some exceptions. There was definitely a rollback on lawfully residing immigrants receiving Medicaid. Just to be clear, no federal money can be spent to provide comprehensive Medicaid coverage to undocumented immigrants. That's never been the case. Any state that's covering undocumented immigrants is doing that with their own state money. But this actually narrows the immigrants with legal status who can receive Medicaid coverage, particularly some asylees and refugees. And then there are other ways in which the bill caps states' ability to set payment rates for certain providers. And there are also, similar to some of the SNAP provisions Cynthia talked about, some penalties a few years down the road for states that have payment error rates. I should say, this isn't fraud. These are really paperwork error rates in Medicaid above a certain threshold. It's a lot of moving parts. In terms of the timeline, a lot of these do not take effect until 2027, are some of the bigger ones. And so immediately there are a few, but this is just the changes that are affecting expansion states. So in addition to removing what was a really big incentive for states to expand, this work requirements for adults and more frequent eligibility checks for adults are what a lot of people have their minds around. And also mandatory cost sharing. So every state has to implement some level of cost sharing just for the expansion adults. And in all these cases, this is just the expansion adults on this slide. States are allowed to are required to charge cost sharing for medical visits up to $35. And we know the more people have to pay out of pocket for their health care, the less they're likely to utilize that health care or even get covered in some cases with premiums. So mandatory work requirements. This, for the first time, sets a mandatory standard for work reporting requirements for every single state. And they are pretty harsh in that they requires anyone, in order to receive Medicaid and enroll and be eligible to enroll, they have to have had at least 80 hours of work in the prior month. So you can't even start to enroll unless you can show you've been working 80 hours in the month prior. And that's a combination of work, school, volunteer activities. And there are a number of exceptions for folks. So parents of caregivers for children 13 and under, pregnant women, certain folks with disabilities or different kinds of disorders, or folks who are taking care of people with disabilities. At the biggest picture level, the exceptions are great on paper, but we have a lot of questions about what are the paperwork requirements or what are the burdens on families to prove that they might be exempt? And we can talk more about that. Because what we've seen in terms of Arkansas's and Georgia's experiences with work requirements is they don't improve employment. They actually, in some cases, anecdotally serve to keep people from getting to work when they can't get their needs met. And just create a lot more red tape for everyone involved, including the state administrative officials. I mentioned provider taxes earlier. So expansion states have to phase down the rate at which they can even have provider taxes. If they have provider taxes that are above 3.5% of the hospital inpatient revenue rate, I'm sorry, hospital patient revenue rate, or provider patient revenue rate, then they have to phase that down over the next few years. Non-expansion states also can keep theirs at 6%, but cannot create new provider taxes. It's just a lot on the financing and making that state match work. So there are some things that impact non-expansion states. I mentioned provider taxes. That really ties states' hands in their ability to raise that revenue. It also, I mentioned, but for every state, it really restricts the types of legal immigrants who can enroll in Medicaid, with a few exceptions. I would say states do have an option under the Children's Health Insurance Program to provide coverage during their first 5 years in the country to pregnant women or kids. That actually still stands. So if a state has adopted that CHIP option, then it might be a mitigating factor for some pregnant women and kids who would otherwise lose their eligibility as lawfully residing immigrants. The other piece here is that the bill for every state restricts retroactive eligibility. So retroactive eligibility is a look-back period for reimbursing costs. So if a family, if a child is enrolled in Medicaid on January 1, it would go back to October 1st for any costs incurred as long as that child was eligible during that prior 3 months. This actually shortens that time period to 60 days for all Medicaid groups, including children. For the expansion population, it reduces that to the 30 days retroactive eligibility. So that really could mean more out-of-pocket costs for families if they don't get that application in on time. We're really concerned about NICU babies, right? Medicaid is a wraparound or a secondary insurer for private insurance in a lot of cases. And, if that application, for whatever reason, families aren't sure what the costs are going to be or what the insurance company is going to cover, how long will that look back period be where Medicaid can help defray some of those really costly and unexpected healthcare costs? So that's a lot. There's a lot coming, most of it in 2027, some of it now. And there's a lot of unknowns. A lot of ways in which states might react to what are really a lot of budget hits and administrative hits to implementation. So what we do know is it's a big budget hit, right? It's almost $1 billion over the next 10 years that is going to be passed along to states. And the congressional budget also estimated that roughly 10 million people are going to lose coverage based on HR 1. About 7.5 of those will be Medicaid, 7.5 million. So other estimates say there are more folks that are going to be at risk of losing coverage with work requirements, different studies. But there will be coverage losses and there will be budgetary impacts on states. And if you just look at the budget cuts, you'll see they start out small, but they just continue to get bigger over time. So if a state, every state will be impacted differently, but if the state doesn't feel the next 2 years, it's probably coming later, if not earlier. So I wanted to give an example of 2 different states, right? Here's national, just the Medicaid impacts, nearly 1 billion and 7.5 million people who will potentially lose coverage. In Arkansas, which expanded Medicaid, that's about 8 billion over the 10-year period and close to 100,000 people that are at risk of losing coverage estimated. In Tennessee, hasn't expanded Medicaid. Still, it's going to be a $7 billion budget hit potentially to the state of Tennessee, and 25,000 people, give or take, who would lose coverage, which could include many kids. As I said, we are worried about this unwelcome matter-of-fact where adults, for whatever reason, are losing coverage and their children end up losing out too and falling through the cracks. So the reason we talk about the budget numbers a lot is because Medicaid is the largest federal funding source going into states. We took the National Association of State Budget Officers data and just looked at the federal and then split out the state categories of spending. So Medicaid's the biggest, right? Well over half of the federal money flowing into states. If you took this same pie chart and just looked at state money, K-12 is the biggest expenditure line item, right? And Medicaid falls to second, third, or fourth, depending on the state. So that is why we're very concerned, not only about the health cuts that could mean, taking $1 billion out of the healthcare system is going to hurt everybody, not just those on Medicaid, but it also puts a lot of strain on state decision makers who are trying to make their budgets work, because unlike Congress, the state lawmakers have to balance their budgets every year. So these are the kinds of choices within the health system that states have, right? If they want to keep Medicaid as is, but they need to make cuts, for some populations, they could close their cap enrollment. For some, and I should say, for eligibility, even 1 out of 5 children is an optional coverage category, right? There are federal minimums for all the required folks to be covered, but most states have gone well above those for optional, right? States could add even more red tape to enrollment and eligibility, cut benefits back, any optional benefits or optional payment rates. They could cut provider rates and lower reimbursement, or pass more of those costs on to families. What we're really worried about, though, is what happens if the state wants to keep the healthcare system as it is, and we have to really pit different areas of state funding against one another, when we know from this very roadmap that families rely on so many different aspects of state systems and care. And so we might be hurting the same families if we rob Peter to pay Paul. So I think there's a lot to monitor the effects of this bill on states. We are certainly already seeing state budget impacts and discussions about what this will mean in terms of some states trying to think about special sessions. Rural hospital closures are top of mind. Those were already at risk and happening, and we worried that they're going to accelerate. Costs are about to go up. Congress didn't extend premium tax credit subsidies that were on the table. That was something they could have added, but that means a lot of Americans are going to see significant increases in their premiums for the marketplace. That's not specific to HR 1, but I do think it provides a preview, if that happens, to what we're going to see in terms of coverage losses later in Medicaid. There's a lot of, this is confusing, right? Just explaining who's exempt to work from work requirements and other aspects of this is hard to keep track of. So we've got to think about, there's going to be a lot of misinformation about who is impacted and who isn't. You know, if you're an adult and you're covered Medicaid in a state that didn't expand Medicaid, you don't have to worry about work requirements in most cases, right? So I think there's just a lot of confusion as this rolls out, even in the 2 years before this even goes into effect. Speaking of work requirements, I cannot overstate the amount of work it's going to take for states to implement a successful work reporting and requirement system that makes sure eligible people stay enrolled. It is very difficult when you add more red tape like that to keep people covered who have done everything right. And not to mention just getting those set up is an incredibly large task when we already know state Medicaid systems are strapped. And I know I'm nearing time, so I'll say one more thing and I'll go quickly. There are other things happening at the federal level as well. The Center for Medicare and Medicaid Services under the Biden administration approved 9 states to offer continuous eligibility for children between birth and age 6. Some states were approved for 0 to 3. Most of these states were approved to just make sure that when a child is born, they have Medicaid coverage and it stays till they hit kindergarten, which really reduces this churn effect that keeps so many eligible children uninsured, even though they're still eligible. And so we worry about that, of course, during the younger years, especially. So CMS announced back in July, a few weeks after this bill passed, they're no longer going to approve Section 1115 waivers for this specific policy moving forward. And they're not going to renew the existing waivers in place. So there are a few that are in place, particularly Washington, Oregon, and New Mexico, who had an early start. Definitely going to want to watch those. We want to see these and see how they work so we can study them. And it's disappointing that such an innovative policy that would really protect a lot of young children from some of these policies ahead and hold them harmless. I'm sorry to see that not every state's going to have the chance to try that. The Rural Health Transformation Fund was something that was created by HR 1 as a bit of a stopgap to some of the concerns about rural hospital closures. And I think last week or week before, CMS announced state applications. States are applying for those funds right now and can get a minimum for anyone who applies of $10 billion a year for the next 5 years. And some states that could really go a long way. Overall, it's not going to offset what we think are the costs of those kinds of rural hospital closures, but certainly an important opportunity. And we think an important opportunity to try to invest in preventive care and the services, particularly in rural areas that pregnant women and their families and young children might need. So it's clear the work is going to be at the state level for the next few years, just around implementation. But as I said, I think we're worried most about those budget hits. So how can states get creative? States are usually the ones leading us, right? They're usually the ones innovating to help make federal policy change. And so how can we make sure that the folks who are trying to do the right things for young families are at least aligned in their goals and can think creatively about how not to pit different groups against one another? These are the trade-off, or figure out what those trade-offs might be. There are states that have done budget analyses of HR 1 impacts. There are a few linked here. If you're in a state that hasn't done that, I highly encourage you to ask your state law. I mean, this Congressional Budget Office figures and Kaiser are great places to start, but it would be great if each state agency or the state budget officers could get a handle on what they think that impact might be. And then just trying to understand, as this law goes into effect, what the impact is in the near and the long term, and what the stories of these very families are. How are they experiencing this? What has the impact been on their health or their access to needed services? I think I've mentioned all of these. We have some reports and other pieces around state readiness to implement work requirements, looking at things like call center wait times and other data points that we can share. I think really engaging in budget discussions at the state level and a lot of these discussions around how work requirements, it's hard to tell how much flexibility states are going to have with work requirements until we see the exact rules. There are some places they could be more restrictive. There are other places, like with the exemptions, that states can't be more strict, are not allowed to go be less generous. And so, we'll hopefully know more as we get those rules. But a lot of this is going to be just how do we get it implemented in a way that works for families. Last but not least, I want to leave you on a high note because there's a lot of challenges ahead. First is, I mentioned that some of the policies in the Biden administration to streamline and make eligibility processes easier especially for everyone in Medicaid and CHIP were paused or halted for the next 5 years. For a variety of reasons, that didn't apply to states that have separate children's health insurance programs. So if you're in one of the 30 states that has a separate children's health insurance program, there might be opportunities to implement some of those protections if you haven't already. So for example, eliminating waiting periods or premiums that you're supposed to be doing, hopefully anyway. I think I mentioned one of the CHIP options to cover lawfully residing pregnant women and kids during their first 5 years. If you're a state that's taken that, that could be a mitigating factor. If you haven't, that might be something to consider to help make sure those rollbacks to immigrant families aren't as steep. And I'll just say here, I think it's about 1 in 4 children is in a mixed immigration family or mixed status family. And so really important to do what we can. The chilling effect on immigrant families right now is already incredibly challenging. And so, there might be ways to mitigate some of this, but it might be that it's, there's already a lot of damage done. But last but not least, as I mentioned, Medicaid's pediatric benefit didn't change. It didn't change directly coverage for kids. And so there's been so much work to really shore up for young children, especially the way that we can help update what we know is best practice in the health system for young children and their parents. Let's do more to reflect that in EPSDT and how states are implementing that. So I think that's still an opportunity for states to do well by young children. We have more resources. I am going to stop there because that was quite enough.
Well, no, I think that people would want even more, Elizabeth. Thank you for sharing. And it's so complex. And I'm going to wrap us up in the last 13 minutes to share a really exciting new tool that we have for everyone to be able to look at what their states are doing. Many of you over the last years have come to know our policy impact calculator. And this year, for the first time, we made it interactive. So for those of you who are joining us for the first time, I'd like for you to meet Lena. And for those of you who have known her before, you can see she even has a new picture. But Lena is a single mom who has an infant and a toddler, and she works full time all year, and she earns her state's minimum wage. And she receives the benefits that she's eligible for, which is not like everyone. And she files her taxes. So she gets all of her tax credits as well. She takes 12 weeks of leave following her infant's birth, which she's eligible for at the Federal Family Medical Leave Act. And if her state has paid leave, then she gets those benefits that she's paid into as well. And because she's working, she sends her children to childcare, and she sends them to a center that charges the equal access target, that's 75th percentile of the market rate. What we wanted to do is to show how, when you take into consideration wages of a full-time worker, their medical leave benefits, their out-of-pocket childcare costs, the federal nutrition and tax credits, and state taxes and tax credits. Kind of what does it look like when we put all that together in terms of the level of resources a family has? And this year, you can see the difference between the top and bottom is just growing, actually. In Colorado, Lena would have access to over $56,000 a year in resources, coming largely from her wages, whereas in North Carolina, she has less than $21,000 in resources, mostly because her wages are not protected by paid leave and her out-of-pocket childcare costs. So we really encourage you to use this new interactive calculator as a tool to explore how your state ranks and how it's ranking over time, to look at what Lena's story really looks like. And I'm going to show you what it looks like in Colorado, but you will see that for your state, you can print it out. You can use it in PowerPoint slides yourselves or leave behinds. And it allows you to compare not only your state over time, but your state with other states, and to simulate what would the resources be if we were to make certain policy changes. I will say this is our first iteration. We continue to we will update it with more family structure types, more policy interactions, and so forth. But there's a lot for you to explore right now. So let's see how Lena in Colorado gets to over $56,000 in resources. It starts by the fact that she works full time all year round and earns nearly $15 an hour. And so that leaves her with a little less than $31,000. But remember, she did have to take those 12 weeks off to bond and heal from the birth of her child. And in doing that, that would make it so that she would lose a little over $7,100 of her earnings. But because in Colorado they have a paid family medical leave program of at least 12 weeks, then she gets a lot of that back. It protects $6,400 of those earnings. Now, if she did not have a child care subsidy, she would have to come up with nearly $29,000 in child care to cover the cost of her two children. But because Colorado really reduces those out-of-pocket child care expenses, she has to pay less than $1,000 out of pocket for her care. Now you add in the federal SNAP and WIC benefits, as well as the federal earned income tax credit and child tax credit, also the taxes to the left there that she has to pay out. And that adds substantially to her resources. But Colorado also has a very generous state earned income tax credit, as well as a child tax credit that really pushes her resources up and makes it so that she has over $56,000 in resources to provide housing and transportation and food and other necessities for her family. And that makes it so that they rank first. But you can go and use the interactive tool to see how your state looks over time. And you can see here in Colorado, in 2024, they both enacted their paid family medical leave program, as well as more generous child tax credits. And they've added almost $25,000 in benefits to a working family in Colorado over the past 5 years. You can also use this to show how your state compares to others. So here's a group of states that are all very near to one another, but you can see this wide variation in the level of resources that Lena has available to her. And remember, she's doing the exact same thing in every state. She's working full time. She's sending her children to child care center. She has taken 12 weeks off. But you can see in New Jersey and New York that have paid leave programs, a lot of her earnings are protected. More so in New York than in New Jersey because her out-of-pocket child care expenses are lower. And in the states that have those navy blue bars, those are state earned income tax credits, and the lighter blue bars at the end are state child tax credits. And so again, a working family in these different states has access to quite a few different resources. And you can compare your state to the ones that you think make the most impact on those who are making policy decisions. You can also explore to say, well, what if we made changes? So this is Pennsylvania again. And everything is relative to that baseline of what they look like today in 2025. And it shows, well, if we were to increase our minimum wage, what would that do? And you can see that that's about $6,000 more if they made a minimum wage of $10 an hour for Lena. What if they implemented a paid family medical leave program or earned income tax credit or state child tax credit? Now, their out-of-pocket childcare expenses are already relatively low, and so that may not be a priority where they would begin. But this just shows you how these different policy choices lead to different levels of resources for a family. And like I said, over time, we're going to be able to show you, well, what if you did more than one at a time? Um, and on the tool, you can look at different wage levels for the family, and you can look at what it looks like once you've adjusted for cost of living expenses. There's a lot of different kind of resources and information provided for you. So I highly encourage you to check out the calculator, and you can again look at how your state ranks. You can tell Lena's story. You can simulate all sorts of policy choices. And because this is our first time out of the gate, really, with this calculator, we definitely want to hear from you about how you're using it and how you would like to use it, how we could maybe update it to make it even more useful for you. And if there's information that you know, boy, well, we're not modeling this, we actually want to try to implement this sort of policy change, reach out to us and we will do everything we can to model that for your state so that you can really see how that would make a difference for a family in your state. So reach out to us about our policy impact calculator. Also, I just want to kind of reiterate some of the things that we talked about today and encourage you as you move forward in your planning for the next legislative session to use the resources that we've pulled together for you and the resources that the field provides in general, because we are really here to help you meet your policy goals. We know what actually works. We are continuing to try to build the evidence base. We're trying to find policies related to housing, for instance, and much more broad areas. And as soon as the states are implementing them and evaluating them, we will continue to bring to you the policies that work the most. It was great to see all of the energy at the state level. We are going to be following what happens next, and we're a little concerned as states have to grapple with budget changes, what that's going to mean. And we're going to be monitoring how the federal policies are impacting states and their ability to meet the goals that they have for their families. But please check out the new tool that we created for you and reach out to us. So the Policy Impact Center, our whole mission is to be a resource for you as you try to advocate or make decisions about how families can thrive in your state. And we provide nearly everything that we do for states at no charge. So whether it is a benefit cost analysis, if you are thinking about a paid family medical leave program or cost modeling for that or earned income tax credit, if our staff can provide some sort of testimony on a bill, we can't support one way or the other, but we can tell you what the facts say and what the evidence brings to bear. We give presentations all the time about your state's roadmap, how you're doing, or maybe a particular policy area that you want us to dig in deep on. The single most, frequent question I'm asked is, well, what are other states doing? And we have a lot of information about that that we can prepare for you. It's in the existing profiles, but that's something, what's possible and what are states like your state doing? We do program evaluation and all other sorts of research for you. And if we don't know the answer to something, which, there's maybe a few things that we don't know the answers to, we will connect you with the experts in the field who can answer those questions for you. So that's the role that we really want to play. But thank you so much for joining us. Some of you joined us for your 6th time. Some of you, if you count the December event, joining us for 7 times. We just appreciate so much all of the effort that states are making to pass policies that we know will make a difference in the lives of children and families. And we are here to support you. So thank you for everything that you do. And I hope that you have a great rest of your afternoon. Thanks again.